Morning. As everybody starts piling in, I just wanted to say welcome back to Breakfast with the Chiefs for the 2019-2020 season. It should be a very good and interesting season, and we're going to get started in about a minute or so. Just a couple quick housekeeping notes. For those of you who have not attended for Breakfast with the Chiefs, a fair number of you have before. There should be some time at the end for Q&A. I will have a mic, and I will run around and answer your questions, or sorry, not answer your questions, give you the mic to allow you to ask your questions. And before that, though, these events are not possible without the support of our sponsors. So very quickly, supporting today's event, the Canadian Foundation for Healthcare Improvement, the Canadian Institute of Health Information, Medtronic, Novari Health, and of course, thank you for the facility, Sinai Hospital. And without further delay, Chris, it's all yours.
Well, thanks very much, and thanks to everybody for coming this morning and helping us kick off this season of Breakfast with the Chiefs. My name's Chris Simpson. I'm from Kingston, and I thought it would be important to start off with some disclosures. I am the Chief Medical Information Officer for Novari Health, which is a company that has developed and has deployed several wait time solutions and wait time management solutions, virtual care. I chair Ontario Quality Standards Committee for HQO, which has some implications for this talk. And I offer these all really more to just give you a sense of the vantage point that I'm coming from and the things that have influenced me over the years. I'm the Vice Dean Clinical in the Queen's Faculty of Health Sciences. I'm the President-elect of the Canadian Academy of Health Sciences, former Chair of the Canadian Wait Time Alliance, which many of you may remember. And most of the time, I'm an academic and clinical cardiologist in heart rhythm disorders. I neglected to put this here, but I was also a former president of the Canadian Medical Association. So to start off, I'd like to start by sharing my own experiences with wait times in our system, because there's a long history of long wait times in Canada for medically necessary care, and I think it's instructive to review some of this history to help us understand where we are today. My very first exposure to the medical wait times issue was way back at the beginning of my medical career. And it's hard to remember now because cardiac care in Ontario is now really world leading in many ways, and it's so much better now than it was then. But in the late 80s, the access to bypass surgery, cardiac bypass surgery in Ontario was absolutely abysmal. We had patients being sent to Detroit and to Ohio for surgery. People were dying on the wait list, all faceless people, I suppose, for quite a while, until somebody named Charles Coleman died while waiting for bypass surgery after having been postponed 11 times. And that was the event that, for whatever reason, generated sufficient public outrage to trigger some political action. And so the Cardiac Care Network was born and was given a mandate to monitor and report on wait times for cardiac surgery. They set standards, they established triage categories, they established wait time benchmarks for different triage categories, and resources were provided to monitor the adherence to these standards. And then over time, the outcomes actually started to improve. The system goal was to get the mortality rate on the wait list down to 0.5% or less, and it was between 2 and 3% at its worst. And even though the complexity and the average age and the sickness of people got more and more complex, the wait times did go down, and the mortality on the wait list did go below 0.5%. So this has been an unqualified success. It was established as a world leader, one of the only, or the first one of its kind in the world. But it took tremendous time, tremendous resources, and a very single-minded commitment to improving the experience for bypass surgery patients. But only about 1% of all people with cardiac disease need bypass surgery. So what about the other 99% of people with heart disease in Ontario and in Canada? What about all of the tests and the procedures that they need? So I'm a heart rhythm specialist. I look after patients with electrical disorders in the heart. And from my vantage point, the huge focus on bypass surgery, as noble and as successful as it was, didn't really go far enough. Because my patients were dying on the waiting list too. And this is one, Mrs. L.S. She was 49, mother of two, grandmother of one, had been unfortunate enough to have a heart attack a couple of years earlier that was caused by a blockage in just exactly the wrong place, just bad luck, right at the top of her left anterior descending coronary artery, left her with a huge scar on the front wall of her heart. And the problem with scar on heart is that that places people at very high risk for sudden death from cardiac arrest. In fact, 35,000 Canadians die from this every year. And so what she needed was an implantable cardioverter defibrillator, or ICD, which is a pacemaker-like device implanted in the left upper chest, and it monitors the heart 24/7, and in the event that you're destined to have a cardiac arrest, it will detect that, it charges itself up and delivers a shock. So there's a robust literature supporting this, robust guidelines supporting this. But this was now 2003, and wait lists were many months and often years for these to be implanted. And people died while they were waiting. Not just a few, but a lot of people died while they were waiting for these things. And this is the story that motivated me to become interested in weight issues. And it's important to sort of pause and just reflect on why this was so devastating for us who cared for these patients. And the best way I can explain it is that if a patient with heart disease dies, and you look back in retrospect and you say, well, they could have been on a little bit of a higher dose of beta blocker, or maybe I didn't have the statin dose quite high enough. We can think about these in a system way, but it's hard to sort of attribute a specific decision like that to the death of the patient. In other words, the patient didn't die because their Lipitor dose was 40 milligrams instead of 80 milligrams. But when someone waiting for a defibrillator drops dead from an arrhythmia, I know that they died because and only because they didn't have this implanted. So it was an extraordinarily powerful motivator to do something at the policy level. And you often hear researchers talk about, the clinical researchers, they'll say, well, I saw a patient, there was an unanswered problem, it motivated me to pose a question in a research, for a research trial. I designed, we carried out the trial, we got the answer, and then I could apply the result to my patient. Very, very compelling story. But in this case, there really was no knowledge gap. We knew what the problem was and what the treatment was, but what was missing was policy that could deliver the treatment in a timely way. And so for me, over my career, it's been stories like this that have driven my interest in changing the way we do things rather than looking for new knowledge. And so we assembled ourselves and we established a wait time benchmark for defibrillator implantation that still stands today as the gold standard. And we just took a very simple approach. We said, well, if the standard for bypass patients is that we don't want any more than 1 in 200 of them to die on the wait list while they're waiting, then we can calculate what the wait list would have to be for a defibrillator patient, because we know from the trials, as the curves separate between placebo and defibrillator, we know how many will die over a certain period of time. And so if we accept the premise that we want people waiting for a defibrillator to die at no greater rate than patients waiting for bypass, then the wait time benchmark should be 8 weeks. So in other words, if everybody waited 8 weeks, the mortality on the wait list would be 0.5%. So this benchmark was rapidly adopted across the country. It informed resource allocation and informed performance management targets. And then we just kept going. We said, okay, let's establish evidence-based wait time benchmarks for all heart rhythm procedures, also known as electrophysiology procedures. And then the cardiovascular community mobilized further, and we created a whole suite of wait time benchmarks for all cardiovascular consultations and tests and procedures, from diagnostic testing to heart failure, from stenting to bypass, from primary prevention to rehab. And so this developed, we were the first specialty in the country to sort of establish medically determined wait time benchmarks as opposed to government-determined wait time benchmarks, which had been in place beforehand. So, do you remember these guys? So some of them may look familiar. So as luck would have it, the Prime Minister of the day, Paul Martin, and the premiers were negotiating a new health accord. So this is now 2004. And a big part of this was, many of you will remember, a $5 billion wait time fund, because wait times were sort of the premier political health issue of the day. And this led to the birth of the Canadian Wait Time Alliance, which was a federation of specialty societies representing the so-called Big Five. These were the 5 priority areas that were targeted by the Wait Time Fund for improvement, and they included cardiac care, specifically bypass surgery, sight restoration, meaning cataracts, cancer care, and particularly radiation therapy, imaging, CT and MRI, and hip and knee replacements. So these became known as the Big Five. And why these were chosen, I'm not really sure. I suspect it was a combination of political and the fact that there was some, these were high-profile kind of conditions. So I was there as the cardiology community representative, and here we are meeting with the Prime Minister and Health Minister Dosanjh at that time. And together we developed medically determined benchmarks for all of these tests and procedures, published them in peer-reviewed journals, and then we began reporting on provinces' adherence to these benchmarks using the province's own publicly reported data. The government soon changed. You recall Mr. Martin had a minority government, and he was defeated by Mr. Harper, and the Conservatives formed a majority government. And early on, by the end of his term, Mr. Harper wasn't interested in healthcare so much anymore. But at the beginning, he was very interested, actually, in picking up on this. And what they decided to do was frame it as a wait time guarantee. And they decided to offer some resources to provinces who would adopt one of our benchmarks and commit to adherence to those benchmarks. And they could choose whichever one they want. What happened was all of these provinces chose radiation therapy as their target, and the cynical view might be that that was because they were already at or near their targets for radiation therapy. Afterwards, I think after there wasn't really a whole lot of movement or tangible improvement in wait times for other things, the notion of the wait time guarantee sort of faded into the political background. So over time, we continued to grow, and we expanded to 17 national specialty societies. We also brought in the College of Family Physicians, the CMA, that's the Canadian Medical Association, not the Country Music Association, served as the secretariat. And together we established and published over 1,000 wait time benchmarks, medically determined wait time benchmarks, for a broad array of consultations and tests and procedures spanning the entire care continuum. So everything from mental health to emergency department visits to waits for a colonoscopy. And we kept publishing our annual report cards. We pressed provinces to establish wait time websites, and now every province has a wait time website where information is available to the public. We graded them on the quality of their websites. And every year we generated quite a lot of press, actually, that had usually several days of hang time. And it was typically, the report was discussed on the floors of legislatures across the country, as well as in the House of Commons. And I have a few good pictures of opposition members in particular holding up a copy of our report as they spoke. So it was, for several years, a fairly high-profile event. Here's a screenshot from Ontario's wait time website today. You can see the format is easy to read. Right away, within 5 seconds, you get a sense that performance in this area is generally good. This happens to be from the page for access to bypass surgery. 95% of all cardiac surgery patients were treated within the target time, and then it gives some extra data on the different triage categories. So if you're urgent or semi-urgent or scheduled. It's very reassuring, I think, for members of the public to see this kind of performance in a truly province-wide system. Here's a snapshot from the Emergency Wait Times website in Alberta. They provide actually real-time information on emergency department wait times, so patients can actually make an informed choice as where to go. So if you want to wait a minute or an hour and 30 minutes, you can go to Rocky View, but if you want to be seen in 51 minutes, you go to Peter Lougheed. But underneath all of these successes is a not so successful subtext. And this is a complex slide, and it's not intended to be read in its entirety. But what I'd like you to focus on are the colors. So this is a table from our final report in 2015. Down the left side of the table are various medical services, so pediatric surgery, endoscopy, mental health consultations, cataract surgery, many others. The second column lists the benchmark, so this is the time in which the service should be delivered to most people. Across the top are the 10 provinces, so they're all being graded. And then we delivered letter grades. So they got an A if between 80 and 100% of people were treated within the benchmark time. They got a B if it was 70 to 80%. They got a C if it was 60 to 70%, and so on, like the grades you would get in school. But now look at the colors. So green means they did better than last year. Yellow means they did the same as last year. Red means they did worse than last year. But orange means there were no data available to measure. So not a single province was measuring wait times to see a psychiatrist for major depression, for example. Not a single province was measuring access to consultation and treatment for chronic pain. Only 2 provinces were measuring wait times for pediatric surgery. So a sea of orange, meaning that no one was really measuring and reporting performance at all. And we decided to display it in this way to highlight the point that although we've had tremendous successes in the big 5 areas, and particularly Ontario did very well getting wait times down for those big 5, that reflects the experience of a very small proportion of Ontarians. Most patients are still living in this world of orange from an access to care point of view. So this is the so-called balloon effect, and this is a bit controversial, but this is the notion that when we squeeze a few care pathways into compliance, we inadvertently create problems in others. And this, in fact, can be argued to be an obligate consequence of a system with fixed resources, or a system that doesn't fundamentally change the way that it does business. So in Canada, our focus on the Big 5 did indeed improve performance in most provinces, particularly Ontario, but it created the illusion that we were improving overall. We didn't pay attention to the other areas that were not improving or were getting worse, or even more worrisome, the areas that were getting worse precisely because some of the other areas were getting better. So here's a little snapshot for you. This is from my hospital, and you may recognize this from social media because unfortunately, or fortunately maybe, it went viral. But this is a form letter sent from a specialist's office to a referring family doctor, informing the family doctor that the wait time for an appointment is approximately 4.5 years. And this is not unusual. This is not unusual. Here's another one from 2016 from somewhere else, explaining that the patient won't be seen for 3 years. And I put this up to show you the inhospitable language that's in this. You can almost get inside their heads as they wrote this because of the overwhelming sense of failure that they feel for not being able to serve patients better. So the caregivers lash out, basically saying, if you don't show up, you're going to the bottom of the list. And this kind of thing really feeds the lack of a customer service vibe in healthcare in Canada, and it's also a major contributor to physician burnout. And how's this for tone deaf when it comes to just general courtesy? If the person named on this computer-generated letter is deceased, please accept our sincere apologies. Unfortunately, that's real. So the debate rages on. Social media has picked it up, as you would imagine. Here's Andre Picard's tweet that created a new hashtag called #CanadaWaits. And I'd encourage you to check it out and just read all the outrageous stories and anecdotes of people who've had wait time experiences that have been less than perfect. So as the discussion around the issue matured, it became increasingly clear that patient care experiences were not single wait time experiences. They were journeys that could be seen from a wait time perspective at least as a series of transactions. In other words, it's not just about the wait to get your hip replaced, it's about the access to primary care in the first place, the wait to access testing, the wait to access a specialist, the wait to access the procedure, the wait to access the rehabilitation or other recovery type services that people need en route to recovery. These things constitute a series of care events which are punctuated by waits in between. And when you start to imagine healthcare experiences as journeys through a series of waits, then you start to see increasing disparities. Now here's one very simple look at how envisioning just two of those waits, in this case it's the wait from GP to specialist, also known as wait 1, and then the wait from specialist to treatment, also known as wait 2. And you can see how when you see this together, it magnifies the delta from a disparity point of view. So a patient waits 15 weeks in Ontario, for example, versus nearly 40 weeks in my home province of New Brunswick. It takes longer to see a specialist than it takes to get the whole experience taken care of somewhere else. And so when we start to put all of these care experiences together into a journey, we start to see a lot of disparities. And even within provinces, we found with our work at the WTA, great disparities from one region to another, and even within LHINs. Disparities and inequities are everywhere when it comes to access to care. I took a look at our HIP wait lists in southeastern Ontario 3 or 4 years ago, found a wait list of over a year for one surgeon and a wait list of 3 weeks for another in a hospital just 40 minutes away. And you have to ask the question, are patients aware of this? Were they offered a choice? Do they even know they have a choice? And I think we know the answer to those questions. So inequity is an important consideration when it comes to wait times. There's an abundance of literature that shows even in robust public health systems like ours, there are tremendous inequities in access to care for just about every kind of medical care. And in Canada, we kind of bristle at this notion a little bit because we like to believe, and we buy into the mythology to some degree, that we provide care based on need. But the real fact of the matter is that those who are able to advocate for themselves, those who know the system, those who are connected in the system, those who are more articulate or demanding, they rise to the top. And this happens very insidiously. People in lower socioeconomic groups tend not to be as empowered to advocate for themselves. And that's, of course, in addition to all the systemic biases that exist in the system already. So very practically speaking, when a family doctor phones me up and I'm in the middle of a busy day and I'm in between cases and they say, you got to move this person up on the list, they've been in my office 4 times complaining bitterly about their symptoms, I'm under tremendous pressure to do that. And when I have no objective triage criteria to fall back on, no electronic wait list system to see what this will do to other patients on my list, the easiest thing to do is to acquiesce. And this squeaky wheel system exists everywhere in Canada. So I would submit that only the transparency that comes with electronic waitlist management systems and public reporting in real time of wait lists can work to reduce this widespread gaming of the lists and start to resolve some of these vast inequities that we see. So as we turn our eye to digital solutions, and I'll wear my Novari hat here for a brief moment because this is one of their slides, it's instructive to imagine this series of transactions in a care pathway with distinct components that are punctuated by waits. So we call these wait 0, wait 1, wait 2, wait 3. And certainly some patients have more complex experiences than this, many more transactions. The arrows can go back and forth, and the patient can circle around through this system in several different ways. But the principles are largely the same. So wait 0 is the time it takes to see a primary care provider. Wait 1 is the time it takes to get a test or to see a specialist. Wait 2 is the time from specialist to procedure or specialized service. And then wait 3 is the time from procedure to rehab or to other resources needed to complete a recovery. So each of these steps creates an opportunity for a digital solution. Virtual care, e-consults, referral management, triage and surgical and procedure waitlist management. All of these tools exist and can be fit together to parallel the way that a patient moves through the system in a typical experience. And all of these digital tools allow the patient to be safely navigated through the system without worrying about lost faxes, and in a way that ensures equity, in a way that ensures adherence to protocols around triage rules, in a way that improves appropriateness and manages performance around wait times and other quality targets. A non-digital environment breeds non-transparency, just like that example I told you about in myelin. Now consider something as simple as the central intake concept. Many of you will be familiar with this. It's a well-known model. It comes from basic queuing theory, and it's employed by the retail sector all the time. Think Walmart. So you enter a common line, somebody at till 12, the blue light comes on, and then you go to the next available person. Business understands that this increases the flow-through efficiency. So a common intake model where there's one queue and the person in the front goes to the next available provider maximizes efficiency and equity within any given triage category. But too many surgical wait lists in Canada are at the individual surgeon level, which is the model on the right. Now that model deteriorates equity. It's opaque from a transparency perspective, so people in those lines don't know what's going on in the other lines, and it increases inefficiency. Now in the common intake model, it's still possible to preserve patient choice in the model, but it's with eyes wide open, because if a patient decides to choose a particular surgeon for whatever reason, they'll understand that that might mean that they're choosing to wait a little bit longer. In the model on the right, patients have no idea what their other options are. But in the common intake model, when we combine it in a proper electronic environment, all the wait time data are available for all patients and all providers to see in real time. So that has a tremendous appeal for equity and efficiency and resource utilization. So these digital tools, like e-consult and virtual visits and waitlist management tools, all deployed systematically across a patient's journey, can help to serve all the dimensions of quality, not just access to care. They can reduce the percentage of patients done outside the acceptable wait time. They can vet referrals through consistent and measurable triage criteria. They can help to reduce duplicate testing and the inefficiencies that come from being on multiple lists at once. And they can enhance the customer service aspect of the care experience, which I've alluded to earlier. So here's the current state for way too many of us. We still have a fax-based system in too many places, in healthcare, in 2019. Numerous primary care providers on the left fax numerous kinds of specialty specific forms to various providers. How many of you in primary care have like stacks of like 80 different forms because everybody likes a slightly different form? Some of these are lost. Some go to numbers that are one digit off. You know all the things that are wrong with the fax-based system. It is far past time to disappear. Here's where we need to go. This is the end state. So no more faxes, but an electronic system that allows primary care to send in requests to a cloud where first people and then eventually algorithms refer patients appropriately to specialized clinics, to tests, to mental health and addictions, et cetera, et cetera. All of this is managed and tracked electronically. Patients get to the right provider or providers at the right time. Appointments can be coordinated, wait times can be managed, duplication and inappropriate tests can be avoided, and the referral system can be performance managed. So this is from the this is from the NHS, but I don't know whether we would just spell it AX with no E or, but AX the fax. Anyway, doesn't that feel good to look at that picture? So how are different waits for different services perceived? And I find this a very interesting area. So as you can imagine, no one wants to wait too long for cancer treatment. So here are some data on tumor doubling time. So if you have prostate cancer over on the left with a tumor doubling time of 300 days, you might be okay to wait for 3 or 4 weeks. But if you've got head and neck cancer and your tumor is going to double in size in 4 weeks, you don't have the luxury of an inefficient system that may well forget you after a referral has been put in because of the lack of electronic resources and the oversight that allows us to afford. So you really don't want to be waiting for your cancer surgery or your chemo or your radiation. Contrast that with hip and knee replacements, which are really more about pain and functionality and, for some, employment. Or contrast that with emergency department waits, or for imaging. Each of these invoke different kinds of emotions, different kinds of fears, different kinds of frustrations, but they all share a need for professional and competent wait list management, not papers on a desk waiting to go through fax machines. They need to be considered in the context as well of the broader system and the available resources in the system. So the imaging test might be to rule out cancer, for example. And in this context, the wait's every bit as important as the wait for the cancer treatment itself. The waits in the emergency department are directly related to hospital congestion. They signal that there's going to be surgical cancellations the next day, and someone who's waited for their hip replacement is going to have to wait a little bit longer. So this critical interdependency of all the pieces of the system are hidden from us because we don't have a digitized, linked experience that help us to see and manage what's happening in real time. So it's been my experience that patients usually don't mind waiting. This is maybe a bit controversial as well. They don't mind waiting if they're confident that it's safe to wait, if they're confident that they haven't been forgotten, if they have confidence in the integrity of the triage, and if there's good communication and good concurrent care during the wait. But you can't do any of this with a fax and paper-based system with no connectivity to other parts of the system. So a suite of digital tools helps to weave together the series of transactions that collectively comprise a care experience and can fit that experience into the larger context of the system and its collective resources. So that's what will help us to achieve the confidence that's required to have patients wait comfortably and safely. It perhaps isn't so much about eliminating wait times as it is managing them better. So it doesn't take a big step beyond all of this to imagine how a mature electronic referral system would work for any number of typical clinical care pathways, including all the ones here, from primary care, which is the medical home for patients. A coordinated approach facilitated by digital tools can help patients navigate through all these experiences and more. Not just the traditional surgical-based pathways on which a lot of these tools have been built, but pathways in mental health and addictions, for example, in diabetes or other typical chronic disease pathways. And we know that these types of pathways are representative of the care experience of most of Canada's patients. Now, this has to be one of the most commonly seen slides in any health policy talk. This is the burning platform. Canada ranks low every year in the Commonwealth Fund survey of 11 peer countries, and on access, we just simply do a terrible job. And this is meant to be kind of funny, but one of the myths of the Canadian healthcare system is that long wait times is simply the price we have to pay in order to have a universal healthcare system, in order to protect that Canadian value of universal access. But this, of course, is false. So, good, cheap, fast. This slide makes the argument you can have 2 out of 3. You know, you can't have all 3. But I think if we look at this in the context of healthcare, I think it's fair to say we're pretty good. We deliver episodes of care that are very good in the moment when you finally get the care. But we're neither cheap nor fast. And I would argue that the solutions that have been offered over the last 20 years have provided more capacity, but they've not really fundamentally changed the way that we do things. And the result of that has been that we've just managed to tread water. We're looking after more people, but we haven't really improved our processes. So digital tools will help us get better value for our dollar. They'll shorten wait times by fundamentally changing the way that we do things. And in my view, this can't happen fast enough. Because not only do our patients deserve better, but I think Canadian taxpayers deserve better value for their money. And I wanted to divert just a little bit into some of the HQO work because I chair their Quality Standards Committee, and I think this is another important angle on access to care. We believe that an integrated approach to standards matters, and we've worked to develop quality standards that apply to all professions and all care settings that set out the evidence and the data, as well as the barriers and enablers to improvement in a concise package. And so together with patients and families who play a major role in the development of these standards, we have decided to take on unwanted clinical practice variation by seeking the best evidence and the best practices and bringing them to a space that's accessible to patients and the care teams looking after them. So, and I think you'll see where this ties into wait times when we start to look at some of these clinical practice variation stats. So here's the emergency department visits for schizophrenia by region in Ontario. And you have to ask yourself, why does Parry Sound see so few schizophrenia patients in the emergency department and Rainy River and others see so many? Why is there such a huge variation in Ontario? And I think you can see this creates an opportunity for improvement in practice. Here's another example, hysterectomies for abnormal uterine bleeding across the province. If you're in the Northeast, you are more than twice as likely to get a hysterectomy versus if you live in Toronto Central. Why is that? Surely the patients don't differ that much. What about this? The percentage of long-term care home residents, 65 years or older, who are using antipsychotic medication by individual nursing home varies from 0 to 75% in Ontario. And we all know the problems that arise from antipsychotic medication use and the impact that that has on the rest of the system. So the issue with unwarranted clinical practice variation not only means that not enough Ontarians are receiving evidence-based care, it also directly impacts access to care for others. So inappropriate care for some directly leads to denied or delayed care for others. And so we developed a suite of guides. These are still in development. Many are still in the hopper, informing providers and patients about what constitutes best evidence. We have a clinical guide, recommendations for adoption, a patient guide, an information and data brief, and infographics that are suitable for tweeting. And so we've covered everything from heart failure to opioid addictions to access to mental health care. And one of the more recent ones is transitions in care, best practices around transitions in care. You're also aware of the Choosing Wisely movement. You all know Wendy, who championed this in Canada, which aims to reduce low-value testing and procedures, and in my mind also highlights another solution to improving access to care, because in most cases, more appropriate care leads to efficiencies that will increase access to care for everybody. So I think to come to an end, I think there are 4 things we can do, 4 things we can amplify to reduce wait times and perhaps more importantly, make the wait time experience safer and more equitable. And the first is common wait lists. But I'll be frank, getting past the long wait list as a marker of prestige thing is a big one. So surgeons who have a long wait list see this as a marker of excellence and have been the single biggest barrier to the establishment of common wait lists. Second, we need modern electronic tools like e-consult, virtual visits, and an electronic waitlist triage and management solution to replace our fax-based system and to help us appreciate the critical interdependencies in all parts of the system in real time. We need to embed appropriateness culture into our triage and treatment protocols, and groups like HQO and Choosing Wisely provide us with packages of solutions that can help. And then finally, we need to commit to more transparency and public reporting. Patients and taxpayers deserve to know about the performance of their system, and that can only come with public reporting. I didn't realize those toggled down, sorry. So, patients who do need to wait, though, communication. This is where our professional responsibility, I think, has to come to the fore. We need to have respectful language. We can't be mad at patients because they're mad at us because their wait is so long. It needs to be personalized wherever possible. There need to be formal and informal touch points during the wait. And we have to be transparent, we have to be honest, and we have to be authentic. So thank you very much.
Okay, so we have a little bit of time for questions. Anybody over here? Right there, I'll start up at the back here.
First, I want to say thanks for really doing a job of comprehensively visualizing the challenges in the system. A couple of quick comments. I'm a product manager, and in healthcare, and also a healthcare specialist, and in healthcare, we design in wait.
Yeah.
We design service, we design in wait. As a product manager, that's an evil. Like, that's just an evil. You don't. Amazon, and I know people are immediately going to say healthcare is unique, never believe that, but every other industry designs out wait. And they do value stream thinking to visualize the complete journey and see where the waitings and the handoffs and the value deprecation happens. Healthcare has to think along those lines: product, value stream, visualizing wait, visualizing the care pathways properly. The other thing I would say is, and fundamentally is, this is not a technology issue. In every other industry, there are technologies that can easily be leveraged for a lot of the problems in healthcare. It is a mindset thing. If we think waiting is waste, from a lean perspective, from every other perspective, think that way, design that way, operate that way, practice that way. Your thoughts?
I think it's very interesting. I think from my perspective, there are certainly inefficiencies that come from waits, but from my perspective, it's the customer service experience and the safety implications that result from the fact that we and the patients believe that they're in a system, when in fact, when we finish with an episode of care, the handoff to the next is very sloppy and incomplete. The information doesn't go with it, and they sort of start all over again. So they have all of these opportunities for mistakes and errors and bad outcomes to occur. And it's at these transition points where all the inefficiencies are born and the negative perceptions are born. And that's where I think some of these electronic solutions can help, because it'll assist with the handoff. But also within an episode of care, it helps us to understand what the universe of resources is out there, and get us away from this sense that, I know one particular exologist and that's who I always refer to because that's who I went to medical school with and that's who I'm referring this patient to, without knowing that there's an equally good solution that's just as easily accessible, but that's invisible to me. So to me, it's the fragmentation and the siloism that's the problem.
Other questions? Okay. So, Chris, as I walk down here, how do we get the system to start offering choice as a patient, right, or to their patients, where they're associated with a certain hospital and they only make the referrals back to that specific hospital, or people that are associated with that hospital when there's other options or other choice? How do we force that system, or not necessarily force, but how do we make sure that they're offering that?
Well, I think if we were to commit ourselves to common wait lists where that made sense, I think that would largely develop. That transparency would begin to come, and patients would be aware that they had a choice. But one very interesting experience with the cardiac care network in the early days is that there was a mandate, and we had to sign off on the bottom of the form that we had informed patients that there were other places that they could be sent to. And collectively, only about 1% of patients elected to go somewhere else. So I think that just adds evidence to my contention that if patients understand that that we believe it's safe for them to wait, and we reduce the wait to an inconvenience, not an unsafe inconvenience, and not a quality of care compromising inconvenience, they much prefer to be closer to home. But there are other examples where the surgeon in the next office, is able to get the case done perfectly well with the same outcomes, and that's where I think common wait lists will expose, I think, some of the siloism and the inefficiencies that come from it.
So actually my question is very similar to that, which is, what we're talking about is a health informatics project of implementing the system, or whatever the system may be. And in that case, there's people, there's process, and then there's the technology. And like my other technologist said in the background, in the back there, the technology part is not hard, and I think hopefully most of us sitting in this room agree that it's necessary. Then comes the people in the process of integrating and implementing in all primary and all specialist kind of offices that don't have the IT infrastructure that a hospital would, and what that is like. And then the people aspect of, if your physician tells you, I know the surgeon, he's a great guy, I think you should go with this surgeon, and then you get the common pool choice. What will people do? Will they trust their physician, who they have a relationship with, or will they go for the kind of queue, the common queue? What are your thoughts on that? Yeah,
it's a great question. I think there's a lot of, they always say beware of the nice surgeon, right? The surgeon is nice because he or she may not be that technically good. I hope there's no surgeons in the crowd. I think, part of it is a desire to kind of protect patients and providers from our own inherent biases, which I think we all know probably don't have any basis in truth, right? We prefer somebody because we like the relationship with that person or the way they treated us. Not that those things aren't important, but there's a lot of, I think, for lack of a better word, sort of misguided preferences for reasons that I think should be explored in a more evidence-based way. The fact of the matter is, I think that there will be some pathways where patient preference will be very, very important, and they will select somebody and wait longer. But there will be other care pathways where it won't matter as much. It's more of a, again, poor choice of words, but more of an assembly line procedural type thing. Again, not to disparage ophthalmologists, but cataracts have become pretty straightforward. I would venture to guess that most patients probably don't care who their surgeon is. But for somebody who's having complex cancer surgery, they build a relationship with a certain care team, it may be very important for them to continue that therapeutic relationship. So I think a common queue system, I think, allows us to preserve that patient choice where it makes sense, but it also allows people to have that experience in a much more eyes-open way. So they know, I could have this a little faster over here, but you're going to be safe, and you're just going to wait a little bit longer, and you can have this person of your choice. It's all about just openness, I think.
Hi. Building on that, I'm sure you know the case of the Martini Clinic where they do prostatectomies, and because they were looking at the actual outcomes by physician, they were able to they realized that one was getting far superior outcomes than the other.
Right.
I think rather than everybody wanting that guy, what they did was they made everybody else as good as that guy.
Yeah.
And everything that you're saying is about data. So, and I think I wouldn't care as much about what my GP said if there was a public, respected source that I could go to and do my own research. Who should own the data or collect the data? Or who should we be advocating for this to happen? Because it seems to be the single most important thing in the shift to value-based healthcare, to e-referrals and outcomes and monitoring and everything.
Yeah, outcomes is always the tough one because, of course, this is resisted by providers and sometimes with good reason, right? So in the early days of cardiac surgery, there was a lot of resistance to reporting individual surgeon outcomes publicly. until they were able to develop a very sophisticated system to account for all the differences in patient characteristics, at which point the outcomes were amazingly identical across the province, every single cardiac surgeon. And I think once that confidence was reached, the sharing of those outcomes became a little bit easier. They're still not shared with the public at an individual surgeon level, but I think we can still say with confidence, like I tell my patients, it really doesn't matter which surgeon you go to. I have very good confidence because I've seen the anonymized data that all of our surgeons have very good outcomes. So I think the resistance is really from the profession. We have to sort of transition away from a fear of being evaluated and having our outcomes subject to public scrutiny. But in fairness, it has to come in a way where we have a lot of confidence in those data. I see a generational shift in that. People of my generation and older are much more reluctant to sort of be subject to that level of scrutiny. Younger people seem much more amenable to that kind of scrutiny. So I think as those barriers come down, I think we'll start to see more and more public reporting of those kinds of outcomes and other system metrics.
Great. Hi, over here. Thanks for your remarks this morning. I guess as you know, Ontario is going through a major transformation with the implementation of OHTs, largely to address some of the things that you spoke to about the difficulties with handoffs of care and trying to make for a better patient experience. But at the same time, there's a risk that then there may be more difficulties being able to move or access services between OHTs if you need to see a particular specialist. And I'm wondering if there's one or two things that you would recommend as to how to best avoid that becoming a new way of segmenting or siloing the system in a different way, and so that we can still make sure that we're achieving all of the strategic and service objectives that we're trying for.
Yeah, I think some of those same concerns were expressed when the LHINs were created. These artificial borders that maybe disrupted traditional referral patterns or care pathways. I think most of the people involved in the early stages of OHTs would be quick to suggest that these aren't borders. They're meant to be sort of collectives that help the vast majority of patients to have a coordinated care experience, but not to disrupt unusual forays out across the borders into places where the service may be provided better or faster, or maybe it's uniquely available somewhere else. So there were a few, you may recall in the early days of the LHINs, a few examples where there were attempts to kind of keep people within a LHIN and not treat them in another LHIN, and that was very quickly quashed. So hopefully the lessons we learned from that would be applied to the OHTs.
We have time for one last question. Any more? With that, then, thank you very much, Chris Simpson.
Thank you.
So our next Breakfast with the Chiefs is on October 8th. It's with the International Foundation of Integrated Care, and that'll be at Rotman. So hopefully we'll see you then. Other than that, have a good morning.